Explain the significance of the minimum alveolar concentration MAC in general anesthesia. How does age, body temperature, and coexisting diseases affect MAC values? Provide examples to support your explanation. Answer: the minimum alveolar concentration MAC is the concentration of an inhalational anesthetic that prevents movement in 50% of patients exposed to a painful stimulus. MAC is a critical indicator of the potency of anesthetic agents, with lower MAC values signifying higher potency. Factors affecting MAC include age. MAC decreases with age. Neonates require higher MAC due to underdeveloped central nervous systems, while elderly patients need a lower MAC as their neurological function diminishes. Body temperature. Hypothermia decreases MAC as colder temperatures reduce brain activity. Hypothermia increases MAC as higher temperatures increase neural responsiveness. Coexisting diseases. Diseases like anemia, hypertension, and diabetes reduce MAC due to altered drug pharmacodynamics and physiological responses. Medications like benzodiazepines or opioids, often used concurrently, also lower MAC. For instance, a young healthy adult may require 1.8% sevoflurane MAC, while an elderly patient may need only 1.0% for the same anesthetic depth. Compare and contrast the use of hyperbaric and isobaric bupivacaine in spinal anesthesia. Discuss the advantages and clinical indications for each type. Answer: hyperbaric bupivacaine contains dextrose, making it denser than cerebrospinal fluid (CSF). This allows the anesthetic to spread more predictably under gravity. It is ideal for precise block levels where patient positioning can control the spread. Indications: commonly used for cesarean sections or lower limb surgeries where a controlled block level is crucial. Advantages: more predictable spread, better control of block height, and effective for unilateral anesthesia when the patient is placed in a lateral position. Isobaric bupivacaine has the same density as CSF, making it less dependent on patient position and reducing the risk of an uneven block. Indications: suitable for longer surgeries where a consistent block level is needed. Advantages: provides a more stable block height regardless of position, which is beneficial for longer duration surgeries. In summary, hyperbaric bupivacaine is preferred for procedures requiring controlled, specific block levels, while isobaric bupivacaine is better for stable, prolonged anesthesia. In ultrasound-guided brachial plexus block for upper extremity surgery, explain the risks associated with intravascular injection and how to prevent it. Answer: intravascular injection during a brachial plexus block is a significant risk as it can lead to local anesthetic systemic toxicity, LAST, causing CNSE, G. seizures, and cardiovascular e.g. arrhythmias toxicity. To prevent this, the following methods should be employed. Aspirate before injecting local anesthetic to confirm that the needle is not in a vessel. Administer the anesthetic incrementally while observing for signs of systemic toxicity such as tinnitus or dizziness. Use ultrasound guidance to visualize the needle tip in real time and avoid vascular structures. Consider test doses of anesthetic with epinephrine, which causes a transient increase in heart rate and blood pressure if injected intravascularly. Ultrasound guidance significantly reduces the likelihood of inadvertent vascular puncture, improving the block's safety and efficacy. Intravascular injection can be further minimized by using the smallest possible needle and administering the local anesthetic slowly. What are the advantages of TIVA over inhalational anesthesia, and in what clinical situations is TIVA preferred? Discuss specific pharmacokinetic properties of propofol that make it suitable for TIVA. Answer: TIVA, total intravenous anesthesia, provides several advantages over inhalational anesthesia. Reduce PONV, postoperative nausea and vomiting. TIVA, particularly with propofol, significantly lowers the incidence of PONV, making it ideal for outpatient procedures. Faster recovery. Patients wake up quicker with TIVA due to the rapid metabolism of agents like propofol. Less respiratory depression. TIVA typically offers better control of the airway, especially in patients with reactive airways, as it avoids the respiratory depressant effects of volatile agents. Clinical situations. TIVA is preferred in neurosurgery where it avoids increases in intracranial pressure in patients with malignant hypothermia, since TIVA avoids triggering agents like halothane, and for short outpatient surgeries. Propofol's pharmacokinetic properties make it an excellent choice for TIVA. It has a rapid onset, 30 seconds short duration of action, and is metabolized in the liver, allowing for predictable recovery. Propofol is also an effective antiemetic, further supporting its use in outpatient and day surgery settings. Mr. Smith, a 45-year-old male, presents for elective abdominal surgery. During epidural catheter placement, Mr. Smith reports a sharp pain radiating down his right leg. What should the anesthetist do immediately, and what are the potential causes of this sensation? Answer: the anesthetist should immediately stop advancing the needle to avoid causing injury to neural structures. The sharp pain radiating down the leg suggests the needle may be in close proximity to a nerve root. Immediate actions: withdraw the needle slightly and reposition it if necessary. Reassess the insertion technique using a loss of resistance approach to confirm proper epidural space placement. Monitor for any signs of nerve injury and adjust technique accordingly. Potential causes of pain: needle contact with a nerve root can cause sharp radiating pain. Anatomical abnormalities, e.g., scoliosis or epidural fibrosis, can alter the needle trajectory. Inadequate local anesthetic may not properly cover the nerve, causing sharp sensations. The anesthetist should ensure proper technique and confirm correct epidural space placement to avoid nerve damage and ensure patient safety. Discuss the differences between conscious sedation and deep sedation in terms of patient responsiveness, airway reflexes, and monitoring requirements. Answer: conscious sedation involves the administration of sedatives to reduce anxiety and pain while maintaining the patient's ability to respond to verbal stimuli. Airway reflexes are intact and the patient can protect their airway. Monitoring typically includes pulse oximetry and blood pressure. This level of sedation is commonly used for minor procedures like colonoscopies or dental work. Deep sedation involves a deeper level of sedation where the patient responds only to repeated verbal or physical stimulation. Airway reflexes may be impaired, requiring continuous airway management. This level of sedation is often used for more invasive procedures such as orthopedic surgeries or procedures in high-risk patients. Continuous monitoring of oxygenation, ventilation, and circulation is critical during deep sedation. In summary, conscious sedation allows for verbal responsiveness with minimal airway intervention, whereas deep sedation necessitates a higher level of monitoring and potential airway support. What are the benefits of using ultrasound for regional anesthesia compared to traditional landmark-based techniques? Answer: ultrasound-guided regional anesthesia provides numerous advantages over traditional landmark-based techniques. Real-time visualization: ultrasound allows the anesthetist to see the anatomy, including the target nerve, blood vessels, and surrounding structures, reducing the risk of complications. Improved success rates: visualizing the needle tip in relation to the nerve ensures a more accurate placement of the local anesthetic, leading to a higher success rate of the block. Lower risk of complications: using ultrasound reduces the risk of vascular puncture, pneumothorax, or intravascular injection by guiding the needle around critical structures. Reduced anesthetic volume: with precise targeting, smaller volumes of anesthetic are needed, which can reduce the risk of toxicity and speed recovery. Ultrasound guidance significantly improves the efficacy, safety, and precision of regional blocks. Describe the pathophysiology, risk factors, and management of post-dural puncture headache. Answer: pathophysiology. PDPH occurs when cerebrospinal fluid (CSF) leaks from the puncture site, leading to decreased intracranial pressure. This causes traction on pain-sensitive structures in the brain, resulting in headache. Risk factors: needle size. Larger gauge needles, particularly those without a bevel, increase the risk of CSF leakage. Age and gender: younger patients and women are more prone to PDPH. Multiple dural punctures. Increased attempts at spinal access can increase the risk. Management: conservative treatment includes hydration, analgesics, and caffeine to constrict cerebral blood vessels and reduce headache. If conservative measures fail, an epidural blood patch can be used where a small amount of the patient's blood is injected into the epidural space to seal the leak. PDPH is a common complication of spinal anesthesia, but with early recognition and appropriate management, outcomes are usually favorable. What are the symptoms, causes, and treatment options for local anesthetic systemic toxicity? Last. Answer: symptoms of LAST can be divided into early and late stages. Early symptoms include tinnitus, metallic taste, dizziness, and numbness. Late symptoms involve more severe manifestations, such as seizures, cardiac arrhythmias, and respiratory depression. Causes: LAST occurs when local anesthetics are absorbed systemically in toxic amounts. Common causes include inadvertent intravascular injection or excessive dosing. Treatment: immediate discontinuation of the anesthetic and airway management are critical. Seizures can be treated with benzodiazepines. Lipid emulsion therapy, injected intralipid, is the most effective treatment to bind the anesthetic and reduce toxicity. Advanced cases may require cardiac resuscitation or the use of antiarrhythmic agents. Prevention involves proper dosing, using the smallest effective volume, and employing aspiration techniques during injection. Discuss the anesthetic considerations for obese patients undergoing surgery, including airway management, drug dosing, and positioning. Answer: airway management. Obese patients have a higher risk of difficult airway management due to shortened neck, reduced mobility, and increased fatty tissue around the airway. Preoperative assessment of airway anatomy, including the Mallampati score, is crucial. Airway management tools like a videolaryngoscope may be required. Drug dosing. Induction agents should be dosed based on lean body mass to avoid overdose. Local anesthetic doses must also be adjusted based on weight to avoid toxicity. Positioning. Obese patients are at higher risk of pressure sores and compartment syndrome due to prolonged surgical positioning. Careful padding and repositioning are necessary to reduce these risks. Overall, the anesthetist should take precautions, including adjusted dosing and enhanced monitoring, to ensure the safety of obese patients during surgery. What are the key safety features of modern anesthesia machines designed to prevent hypoxic gas delivery, and how do they function? Answer: modern anesthesia machines incorporate several safety features to prevent hypoxic gas delivery. Proportioning systems. This mechanism maintains a fixed oxygen to nitrous oxide ratio, typically ensuring at least 25% oxygen, preventing oxygen levels from dropping too low. Oxygen failure protection failsafe. A failsafe system shuts off or limits the delivery of nitrous oxide when the oxygen supply pressure falls below a threshold, ensuring oxygen continues to flow if nitrous oxide is unavailable. Oxygen analyzer. This device continuously measures the oxygen concentration in the circuit and provides an alarm if it falls below the set level, ensuring accurate oxygen delivery. Gas flow control valves. These valves ensure precise gas delivery and prevent errors due to incorrect settings. These features comply with the safety standards set by ASTM F&I ISO 80601-213, providing a safeguard against hypoxic mixtures and improving patient safety during anesthesia. Discuss the American Society of Anesthesiologists ASAP difficult airway algorithm and its application in clinical practice. Answer: the ASAP difficult airway algorithm provides a structured approach for managing difficult airways. It begins with an airway assessment to identify potential difficulties, e.g., Mallampati score, neck mobility. If difficult intubation is anticipated, preparation is crucial, including ensuring the availability of appropriate equipment and skilled personnel. If intubation fails, the algorithm suggests alternative approaches, such as using a videolaryngoscope or fiber optic intubation. In extreme cases, emergency pathways such as cricothyrotomy or tracheostomy should be considered. This algorithm prioritizes early identification, continuous monitoring, and timely intervention to prevent complications. According to the ASA guidelines, the algorithm also emphasizes maintaining the ability to secure the airway at all times and stresses the importance of preemptive planning in all patients. Its application ensures a systematic response, reducing the likelihood of failure in critical airway management. Dr. Patel is administering a femoral nerve block using ultrasound guidance. After identifying the femoral nerve adjacent to the femoral artery, he observes difficulty visualizing the needle tip, raising concerns about inadvertent vascular puncture. What should Dr. Patel do next? Answer: Dr. Patel should adjust the needle approach. Switch to an in-plane technique where the needle is aligned with the ultrasound probe for better visualization. Optimize ultrasound settings. Adjust gain, depth, and focus settings to improve the clarity of the image. Aspirate before injection. To confirm the needle is not in a blood vessel, aspirate before administering local anesthetic. If blood returns, the needle should be repositioned. Inject test dose. After confirming the needle is in the correct location, a small test dose of local anesthetic, G1, 2 ml, should be administered to verify proper spread and avoid vascular puncture. This approach follows guidelines from the American Society of Regional Anesthesia, ASRA, which emphasizes real-time monitoring and safety during regional anesthesia, especially with ultrasound guidance. Continuous visualization of the needle and local anesthetic spread reduces the risk of complications like vascular puncture or inadvertent local anesthetic injection into the wrong structure. Explain the importance of capnography in detecting esophageal intubation and describe the waveform characteristics associated with this scenario. Answer: capnography is a crucial tool in confirming correct endotracheal tube placement. During intubation, the absence of end-tidal co-echo or a flatline waveform indicates esophageal intubation, as no gas exchange occurs in the esophagus. If the tube is in the trachea, a normal capnography waveform is seen, characterized by a curved plateau phase indicating regular exhalation of CO. The waveform should be continuous and correspond with the patient's ventilatory efforts. When esophageal intubation is suspected, immediate reintubation or placement of a supraglottic airway is recommended. The American Heart Association, AHA, and the ASA advocate the use of capnography as the gold standard for confirming tube placement, given its high sensitivity for detecting esophageal intubation. Studies show that capnography significantly reduces the risk of unrecognized esophageal intubation, a critical safety issue during anesthesia. Compare and contrast volume-controlled ventilation, VCV, and pressure-controlled ventilation, PCV, including their clinical applications. Answer: volume-controlled ventilation, VCV, delivers a fixed tidal volume regardless of airway resistance or lung compliance. This mode ensures that the volume of air delivered is consistent, making it useful in patients with normal lung compliance where precise volume control is essential. However, VCV may lead to increased peak airway pressures in patients with conditions like ARDS where lung compliance is compromised. Pressure-controlled ventilation, PCV, on the other hand, delivers a set pressure during inspiration with tidal volume varying depending on lung compliance and airway resistance. This mode is useful in patients with low lung compliance, e.g., ARDS, as it reduces the risk of barotrauma by limiting peak inspiratory pressures. However, the tidal volume may be inconsistent and less predictable. Clinically, VCV is preferred for patients with normal lung function, while PCV is indicated in lung injury states where protecting the lungs from high pressures is critical. Both modes require careful monitoring to ensure optimal ventilator settings and prevent complications such as barotrauma or volatrauma. What is the Cormack-Lehane grading system and how does it guide airway management? Answer: the Cormack-Lehane grading system is a classification tool used to assess the ease of laryngeal view during direct laryngoscopy. It consists of 4 grades. Grade I, full view of the glottis, easy intubation. Grade Roman II, partial view of the glottis, intubation may be difficult. Grade Roman III, only the epiglottis is visible, difficult intubation. Grade Roman, neither the glottis nor epiglottis is visible, extremely difficult or impossible intubation. This system helps anesthesiologists anticipate the difficulty of intubation and plan accordingly. In cases of grade II or IV, alternative intubation techniques such as video laryngoscopy or fiber optic intubation are recommended. The American Society of Anesthesiologists (ASA) guidelines emphasize the importance of this assessment in preoperative airway evaluation, as early identification of airway difficulties helps optimize preparation and equipment choices. Discuss the role of smart infusion pumps in preventing medication errors during anesthesia. Answer: smart infusion pumps play a critical role in preventing medication errors by integrating technology that assists with accurate drug delivery. These pumps contain drug libraries that specify appropriate dosing ranges for various medications, reducing the risk of errors from incorrect dosing or infusion rates. Additionally, dose error reduction software, DES, continuously checks programmed rates against predefined limits, alerting providers if they exceed safe thresholds. Another advantage is real-time monitoring, which ensures that medication is being delivered correctly and alerts the user to issues such as occlusions or infusion interruptions. Smart infusion pumps also log all data, allowing for post-procedure audits and quality assurance. The FDA and ISMP recommend using these pumps in high-risk settings like anesthesia, where precise dosing and monitoring are essential. By reducing human error and enhancing patient safety, these devices are a critical component of modern anesthesia care. What are the indications for using fiber optic bronchoscopy for endotracheal intubation, and what preparation steps are essential? Answer: fiber optic bronchoscopy is used for intubation when standard techniques are anticipated to be difficult, such as in patients with limited neck mobility, airway anomalies, or obstructions, e.g. tumors. It is especially useful for awake intubation in patients with high risk of aspiration or difficult anatomy. Preparation steps include topical anesthesia. Adequate anesthesia of the airway, typically with lidocaine, is crucial to reduce discomfort and prevent coughing. Sedation with agents like dexmedetomidine ensures patient comfort and cooperation during the procedure. Equipment readiness: ensure the fiber optic bronchoscope is functioning correctly with a clear view of the airway and suction is available for secretions. Staff and communication: ensure a skilled team is present for assistance, including those trained in handling airway emergencies. Fiber optic bronchoscopy is an advanced technique that should be performed by skilled clinicians, as it requires precise coordination to safely navigate the airway. Differentiate between cricothyrotomy and tracheostomy in terms of indications and techniques. Answer: cricothyrotomy is an emergency procedure performed to establish an airway when other methods fail, typically in patients with upper airway obstruction or severe trauma. It involves making a small incision through the cricothyroid membrane, usually under local anesthesia or sedation, and inserting a tube to secure the airway. It is often a temporary measure, and definitive airway management is usually required afterward. A tracheostomy is a more permanent procedure performed when long-term airway access is needed, such as in patients with chronic respiratory failure or those requiring prolonged mechanical ventilation. This procedure involves making an incision in the trachea below the level of the larynx and inserting a tracheostomy tube. While cricothyrotomy is rapid and effective for short-term use, tracheostomy offers better comfort and long-term airway management. What are the key components of preoperative evaluation for anesthesia? Answer: the preoperative evaluation for anesthesia includes medical history, a thorough assessment of the patient's medical conditions, e.g. diabetes, cardiovascular disease, and prior anesthesia experiences. Airway assessment, evaluating factors like neck mobility, Mallampati score, and history of difficult intubation. Physical examination, focus on cardiovascular and respiratory systems as well as any conditions that may impact anesthesia, e.g. obesity. Laboratory tests, assessing relevant tests like CBC, electrolytes, and coagulation. Studies based on patient risk factors. Risk stratification, using tools like the ASAV physical status classification to estimate anesthesia risk. The goal is to identify potential complications, plan appropriate anesthesia techniques, and ensure patient safety during surgery. Preoperative optimization of comorbidities, when possible, improves surgical and anesthetic outcomes. During the preoperative assessment of a 65-year-old male with a history of controlled hypertension, type 2 diabetes, and chronic obstructive pulmonary disease (COPD), how would you assign an ASAG classification? Explain the rationale and how this impacts the anesthetic plan. Answer: the patient would likely be assigned an ASAG physical status II, as he has multiple significant systemic diseases that are controlled but may impact anesthesia and surgical risk. The ASAG classification is as follows: ASAI, normal, healthy patient; AS-OMAN 2, mild systemic disease; AS-OMAN for a severe systemic disease with some functional limitation; AS-OMAN, severe systemic disease that is a constant threat to life; ASAV, moribund patient not expected to survive without surgery. In this case, COPD and diabetes introduce significant but not life-threatening risks. Preoperative optimization should include controlling glucose levels and ensuring adequate pulmonary function. The classification helps guide anesthetic risk discussions and intraoperative monitoring. What are the primary differences between crystalloid and colloid solutions for fluid management during surgery, and how do these differences influence their intraoperative use? Answer: crystalloids, e.g. saline lactated ringers, composed of water and electrolytes, rapidly distribute into the extracellular space, requiring larger volumes for resuscitation, useful for maintaining hydration and replacing extracellular losses. Colloids, e.g. albumin hydroxyethyl starch, contain larger molecules that remain in the intravascular space longer, require smaller volumes for resuscitation, higher cost and associated risks, e.g. anaphylaxis, coagulopathy with starch. Choice depends on clinical scenario. Crystalloids for general replacement, colloids for acute intravascular volume expansion, e.g. hypotension due to blood loss. Mrs. Carter, a 45-year-old patient scheduled for elective surgery, had a light breakfast of toast and tea 6 hours before the procedure. What should the anesthesia provider recommend regarding proceeding with surgery? Explain the relevant fasting guidelines. Answer: Mrs. Carter's fasting period does not meet the minimum requirements. According to the American Society of Anesthesiologists (ASAC) guidelines for fasting before surgery, clear liquids, minimum fasting period of 2 hours breast milk, 4 hours non-human milk, infant formula or light meals, 6 hours heavy meals. 8 hours since Mrs. Carter consumed a light meal, toast and tea, she should ideally have fasted for at least 6 hours before surgery. Given that 6 hours have passed since her meal, she may be eligible for surgery if no further complications arise. However, if the anesthesia provider is concerned about potential aspiration risks, the surgery might be delayed or rescheduled to ensure that the NPO guidelines are adhered to, reducing the likelihood of gastric content aspiration. In any case, an additional check of her clinical status, e.g. signs of reflux or GERD, would be prudent to further minimize aspiration risk. What are the primary steps to identify and manage hypotension caused by anesthetic agents during surgery? Answer: hypotension induced by anesthetic agents is a common intraoperative challenge. The following steps can help identify and manage this complication. Assessment: evaluate the patient's hemodynamics, including blood pressure, heart rate, and the use of invasive monitoring like an arterial line. Hypotension may be caused by anesthetic agents, e.g., propofol, volatile anesthetics, leading to vasodilation and myocardial depression, or by blood loss and hypovolemia. Initial interventions: fluids. Administer bolus of crystalloid, e.g., saline or Ringer's lactate, to restore intravascular volume. Reduce anesthetic depth. Decrease the dose of volatile agents or propofol to reduce vasodilation. Vasopressors. If fluid therapy and reducing anesthetic depth are insufficient, vasopressors such as phenylephrine or norepinephrine can help restore blood pressure. Ongoing monitoring. Closely monitor the patient's response to treatment, focusing on urine output and mental status to assess end organ perfusion. What are the key principles of rapid sequence induction RSI, and in what scenarios is it particularly indicated? Answer: rapid sequence induction RSI is a technique used to secure the airway in patients who are at high risk of aspiration, such as those with a full stomach or in emergency settings. The main principles are pre-oxygenation. The patient is given 100% oxygen for 3-5 minutes to increase oxygen reserves and prevent hypoxia during intubation. Induction agents. A short-acting anesthetic, e.g., propofol, is administered, followed immediately by a rapid-acting neuromuscular blocker like succinylcholine or rocuronium to induce muscle paralysis, facilitating tracheal intubation. Cricoid pressure. The Selig maneuver is performed to prevent regurgitation of gastric contents into the trachea during intubation. RSI is typically indicated in emergency surgeries, patients with full stomachs due to trauma, pregnancy, or gastrointestinal obstruction. Elective surgeries in patients with high aspiration risk, those with gastrointestinal reflux disease, obesity, or delayed gastric emptying. Compare the advantages and disadvantages of TIVA over volatile anesthetics for maintenance of anesthesia. Answer: advantages of TIVA: reduced postoperative nausea and vomiting. PONV: TIVA, particularly with agents like propofol, tends to have lower incidences of PONV compared to volatile anesthetics. Stable hemodynamics. TIVA is generally associated with fewer fluctuations in blood pressure and heart rate, making it ideal for patients with cardiovascular risk. No malignant hypothermia risk. Unlike volatile anesthetics, TIVA avoids triggering malignant hypothermia in susceptible patients. Disadvantages of TIVA: intravenous access. Requires reliable intravenous access for drug administration and continuous monitoring of drug effects. Dosing complexity. Unlike inhaled agents, TIVA requires more precise dosing with careful adjustment of infusion rates. Higher cost. Drugs like propofol are more expensive than volatile anesthetics, adding to the cost of anesthesia. What are the indications for intraoperative red blood cell transfusion, and what are the associated risks? Answer: indications for red blood cell transfusion. Hemoglobin 7 g/dL. In stable, non-bleeding patients, hemoglobin 10 g/dL with ongoing significant blood loss, e.g., during major surgery or trauma. Hemodynamic instability, when blood loss leads to poor perfusion or shock. Risks of transfusion. Infection. Blood products carry a risk of transmitting infections, although this risk has been minimized with screening procedures. Allergic reactions. Reactions like urticaria or anaphylaxis can occur, though they are rare. Volume overload. Transfusion of large volumes can lead to fluid overload, particularly in patients with pre-existing cardiac or renal issues. Immunologic reactions. Hemolytic reactions can occur if mismatched blood is transfused, potentially leading to life-threatening complications. Given these risks, blood transfusions should be used judiciously, considering the patient's clinical status and the risk of adverse outcomes. What are the anesthetic considerations for preventing nerve injuries during positioning for surgery? Answer: during surgery, proper positioning is crucial to avoid nerve damage. Key considerations include avoiding compression. Ensure that pressure points like the ulnar nerve at the elbow, the peroneal nerve at the knee, and the brachial plexus at the shoulder are not compressed for extended periods. Padding. Use adequate padding for bony prominences and joints to distribute pressure evenly. Monitoring. Use sensory and motor checks before and after the procedure to assess nerve function. Alignment. Keep the body aligned, avoiding excessive flexion or extension of joints. Proper positioning can prevent complications like brachial plexus injury, ulnar nerve neuropathy, and sciatic nerve damage. How can hypothermia be prevented during surgery, and what are the potential complications associated with intraoperative hypothermia? Answer: preventing hypothermia during surgery involves several strategies. Prewarming. Prior to surgery, patients can be warmed using forced air warming blankets or warm intravenous fluids. This helps raise the body temperature before anesthesia, which can impair thermoregulation. Maintaining operating room temperature. The operating room should be kept at a temperature between 20-24°C-78-75°C to reduce heat loss. Warming systems, such as heated mattresses and blankets, can also be used during the procedure. Warming fluids. Intravenous fluids should be warmed to body temperature 37°C before administration to prevent cooling the patient from the inside out. Insulating the patient. Covering the patient with sterile drapes and blankets during surgery helps minimize heat loss through radiation and evaporation. Complications of intraoperative hypothermia. Cardiac arrhythmias. Hypothermia can lead to bradycardia and increase the risk of arrhythmias, especially when the temperature drops below 36°C. Increased blood loss. Hypothermia causes vasoconstriction and can impair platelet function, leading to prolonged bleeding. Impaired drug metabolism. Reduced temperature slows the metabolism of anesthetic agents, potentially prolonging the duration of anesthesia and recovery times. Postoperative shivering. After surgery, patients may experience shivering, which can be uncomfortable and lead to further complications, such as increased oxygen consumption. Hypothermia prevention is essential to ensure optimal patient outcomes and to minimize complications associated with surgery. What are the key principles for managing postoperative pain in patients after major surgery, and how do multimodal analgesia strategies improve patient outcomes? Answer: effective postoperative pain management is crucial for enhancing recovery and improving patient outcomes. The principles of pain management include assessment. Pain should be regularly assessed using validated pain scales, e.g., numeric rating scale or visual analog scale. The goal is to keep pain at a manageable level, usually below 4 on a scale of 10. Opioid analgesics. Opioids, e.g., morphine, hydromorphone, are often used for moderate to severe pain but should be used cautiously to avoid respiratory depression, nausea, and dependency. A low-dose regimen is typically preferred to minimize adverse effects. Multimodal analgesia. This approach uses a combination of different drug classes and techniques to target different pain pathways. It typically includes non-opioid medications, such as acetaminophen and NSAIDs, e.g., ibuprofen, ketorolac, which reduce inflammation and complement opioid therapy. Regional anesthesia. Nerve blocks, e.g., epidural peripheral nerve blocks, can be used for localized pain relief and reduce the need for systemic opioids. Adjuvants. Medications like gabapentin or steroids can be added to manage neuropathic pain or reduce inflammation. Non-pharmacological measures. Techniques like physical therapy, ice packs, and relaxation techniques, e.g., guided imagery, also play a role in pain management. Benefits of multimodal analgesia. Reduced opioid use. Combining medications and therapies reduces the need for opioids, decreasing the risk of opioid-related adverse effects and dependency. Improved pain control. By targeting multiple pain pathways, multimodal analgesia provides better overall pain relief and enhances recovery. Faster recovery. Effective pain management leads to earlier mobilization and reduced complications such as deep vein thrombosis and pulmonary embolism.